Hi, I'm Allison McCoy from Vanderbilt University Medical Center, and I'm presenting a poster on improving management of pediatric cardiac shunt-dependent patients in the emergency department, or ED, through clinical decision support, which I've worked on with my colleagues in biomedical informatics and pediatric cardiology and emergency medicine. Cardiac shunt dependents are those with hypoplastic left heart syndrome following a stage 1 Norwood, or those with any complex congenital heart defect, or CHD, that results in single ventricle anatomy and resulting cardiac shunt-dependent physiology, whether it's surgically placed systemic to pulmonary artery shunt or a stent placed within the ductus arteriosus. These patients are at a much higher risk for morbidity and mortality than normal children or even other patients with CHDs, especially if they don't receive prompt care. They can be extremely susceptible to minor physiologic changes such as dehydration, desaturations, fever, and infection that are usually well tolerated by other children. Clinical staff, particularly in the emergency department, who are unaware that a patient is dependent on a cardiac shunt can unintentionally cause harm through delays in care due to normal hospital admission procedures. At Monroe Carroll Vanderbilt Children's Hospital in Nashville, Tennessee, we developed a clinical decision support intervention within the EHR to improve management of pediatric cardiac shunt dependence, especially in the ED, to reduce delays in care. We implemented an intervention as an EPIC best practice advisory alert and a flag to identify pediatric cardiac shunt dependent patients and notify staff that a patient has a cardiac shunt. A screenshot of the alert is shown on the right side of the poster. So case managers set the flag within the EHR for each patient after discharge from the shunt procedure. The alert then triggers for all users who open the chart for one of these patients. The alert notifies the user that the patient is cardiac shunt dependent and that care should not be delayed, and it includes institutional guidelines for care. Users are then required to acknowledge the alert by selecting Understood, which suppresses the alert for that user for 24 hours, or Remind Me Again in 1 hour, which suppresses the alert for that user for 1 hour. In the table, you can see median times to triage, provider evaluation, and disposition for ED visits pre and post implementation. So the time to triage and provider evaluation were significantly lower in the post-intervention period, and time to disposition was lower but not significantly different. The three figures at the bottom show Kaplan-Meier curves for time to triage, provider evaluation, and disposition. And similar to the log rank results, we observed a large intervention effect on time to triage and provider evaluation, and little to no effect on time to disposition. We did not observe any episodes of cardiac arrest or CPR for any study patients in either the pre or post-intervention periods. In the 9 months after implementation, 26 patients were identified as cardiac shunt-dependent patients, so the alert displayed to staff 23,918 times, or about 900 times per patient. These most often displayed to technicians, nurses, pharmacists, nurse practitioners, respiratory therapists, resident physicians, physicians, case managers, and fellows. Patients who were admitted to cardiology or the pediatric cardiac intensive care unit most often triggered the alerts. Override comments can be one indicator of frustration by staff, but we reviewed these for this alert and didn't find any indication that the staff were getting frustrated by this alert. So in conclusion, we developed a clinical decision support alert that successfully identifies and notifies staff about pediatric cardiac shunt-dependent patients to significantly reduce the time to care. Thank you.